So I wanted to talk about gynecologic cancers in general. So what are the common cancers we treat, and how are the ways we treat them? So looking at all the technologies in the world of radiation, not all radiation is created equal. So when do we use this type versus that type, so everyone can sort of understand some of the basics of the field. First things first, there's anatomy to know whenever you're dealing with any sort of gynecological cancer, with screening, with any sort of guidelines that we're looking at. And so some of the most common cancers in women include endometrial cancer, so that's the uterus. So you can see on the right-hand side, that's in yellow, and dropping down to the bottom of it in that little brown color is the cervix. And so that's one of the most common ones that I'm involved with as a radiation doctor. Of course, the vagina, lower beyond the cervix, the vulva externally, and so all of these have special considerations. When we look at the risk factors for cervical cancer and vaginal cancer, the most common risk factor is actually HPV infection. And there's risk factors for how people are infected with HIV. There's risk factors in terms of developing cancer related to screening, HPV being able to persist, and some other sort of rare other factors. I think one thing to highlight is that cervical cancer is a somewhat preventable illness. Not all types can, but the majority of cervical cancer can be prevented with HPV vaccination. So that's been around for some time, and if it's delivered before the onset of any sort of sexual activity, and that doesn't mean sex, it can mean any sort of other activities, the risk reduction is almost 100%. If that is delayed for a few years, that risk reduction goes down to about 70%. So those vaccinations and access to that are vitally important, because this is a type of cancer that actually could even be eradicated in our lifetimes. The way that cervix cancer is staged basically is how big it grows and where it grows. So you can look at the image on the right side, looking at the stage 1s, where you can see it, and then stage 2, where it actually grows outside of the cervix itself into those perivaginal tissues. And that's where surgery becomes more difficult, and radiation becomes the dominant treatment modality to cure these cancers. So why do we do chemoradiotherapy? So what is chemoradiotherapy? That's when we do radiation plus chemotherapy actually at the same time. They have synergistic effects, so the chemo can sort of supercharge the radiation to make the cancer cells more vulnerable to the effects of treatment. And occasionally now we're even adding immunotherapy at the same time. So while radiation can kill a cancer where it starts, some of these other therapies delivered at the same time can address the potential microscopic or distant spread of the cancer. And so there have been numerous studies showing that this is the best approach we have so far, and the overall sort of standard approach to these locally advanced cervix cancers has been this chemoradiation approach since the 90s. Does this hold true in the modern era? There have been some people looking at, can you do all of this chemotherapy and then do surgery versus the standard approach? And for now, the modern approach is the same approach that we've done since the 90s, which is this chemo plus radiation approach. In earlier cases, and Dr. Diaz will speak a little more about the surgical approach to some of these cancers, we can actually do less invasive surgeries. However, in these cases, you still have to note that there is some small chance of recurrence. But in more advanced cases, when they do minimally invasive hysterectomies, you actually may have a higher chance of recurrence. I think what this highlights is that it's very important to have a good conversation with your surgical oncologist should you be ever in some sort of situation looking at this, because the type of surgery, the invasiveness of it, can all play a role in what your recurrence risks are and what additional treatments you may need. So what do we usually do? So in a new cervix cancer diagnosis, these are the steps that are usually taken. There's an initial evaluation, usually done by gynecologist or gynecologic oncologist, including a biopsy and staging exams. This is most commonly a PET CT scan and occasionally a pelvic MRI to help look at where it may be growing into. People then meet a radiation doctor to discuss how we basically plan the radiation. Everyone has different anatomy, and we need to take that into account and deliver a personalized radiation plan. We talk about side effects and logistics. It takes 1 to 2 weeks to create the radiation plan after the first evaluation. This is usually done over 5 weeks, the external radiation part, meaning that a beam rotates around you and delivers a little dose of radiation each day to provide some initial shrinkage and downsizing of the tumor. And so this is a very important treatment to have locally, because having to move abroad for 5 weeks of treatment would be very difficult from a family, from a logistical perspective, and that sort of radiation can be safely delivered with standard radiation machines. What becomes a little more tricky is the second part. So after the external radiation is delivered, we often add an internal radiation boost, and about half of the full dose to a cervical cancer actually gets delivered in 3 to 5 internal radiation treatments called brachytherapy. And so that's part of my area of expertise, and I'm going to show you some pictures of what that looks like. Once all the treatment's done, we do scans to make sure that everything's gone. I got some questions last year about the different types of radiation and proton therapy and photon therapy and what is all of that. And it was actually in specific reference to breast cancer. So while I treat a lot of gynecologic cancers, the other major female cancer is breast cancer. And so just to highlight some differences in radiation technologies, we have 3 here. The first one is called 3D conformal radiation therapy. What this is predefined beams. So you can see a beam's entering from the front and a beam's entering from the back. And you can see that there's a lot of dose where those beams are, but otherwise not much dose. The next evolution of radiation therapy is intensity modulated radiation therapy, where the beams go all around the patient at much more angles. And what you see is a little better conformality of the high dose, but you get more of this low dose splash where you see that in gray. And so if you look at the bottom and the middle, the lungs are getting this low dose splash that could raise the longer term issue of lung fibrosis or scarring and those sorts of things. And then the last one is intensity modulated proton therapy. So what protons do compared to other forms of radiation is that they're better at being controlled where exactly they stop in the tissue. So this is relevant to get radiation dose off of the lungs, for example, and actually the most important thing is to get radiation off of the heart. Breast cancer is very, very curable. But even small doses of radiation to the heart can increase your risk of things like coronary artery disease or other heart conditions, and often the leading cause of death in the majority of countries is actually cardiac disease. And so the last thing we want to do is, by virtue of curing a cancer, raising your risk of another competing morbidity risk. So one more slide about these protons. So you can look at the right. If we were treating, for example, a child who needs craniospinal irradiation, what you can do is very nicely have the beam stop right at the bones in the spine so that you're not getting this low dose to all of their internal organs, which can affect growth and development. And so this is one of the main reasons actually we use proton therapies for children who may have a very, very long life to live after their cancer treatment. And so we want to avoid all these low dose splash that you may get with other forms of radiation. And then my last slide on the breast cancer is for the early stage ones, there's all kinds of ways that are great to treat, and this is something that can certainly be done locally. I'm a brachytherapy expert, so in theory that's possible. That's the figure on the left where we actually insert this device that sort of inflates like a balloon, and you deliver the radiation just to that cavity where the tumor was removed. But then on the other side, you can see the external radiation techniques, which are less invasive. You just have to really lie on the table for about 15 minutes. And you can see that there's not really much difference. The one on the left is proton, the one in the middle is the intensity modulated, and the one on the right is the 3D conformal, and all of them are acceptable for these sorts of situations. They have minor differences in some of the lower doses, but really nothing that would be in the long term clinically significant. For cervical cancer, this is an example plan, and so this starts to get a little bit more complicated. We're treating really the pelvis, and so the CT scan image is showing, focused on the cervix where you see sort of that red circle, but in front of it, it's your bladder, and then in front of your bladder you have some bowel. And so we look at the doses of all of these, what we call organs at risk. And really that's what we need to minimize is the doses to the organs at risk. We don't want people to get very sick because they're getting radiation toxicity to their other organs. And part of how we do that is through sort of complicated graphs where we look at exactly what % of what organ is getting what dose. The brachytherapy is the internal part of the radiation that I mentioned, and this is often done in a procedure called a tandem and ovoid implant. So that device is what you can see on the right, and so that's inserted while people are asleep, and people are treated, with anesthesia because this is a somewhat invasive procedure, but this goes into the cervix, and you can see that we have some little needles that basically poke into the residual amount of the tumor, and we can give these ultra-high doses. And so you can see in the red is the residual tumor, and then the dose lines coming around it. So that black line or navy line on the outside is really half the dose, and so you can see that about triple the dose is hitting the center of the tumor with about only a third of the dose really reaching the bladder or the bowel, which is fantastic. For more advanced cases, we sometimes have to do more advanced techniques. So rather than that more simple device, we can actually customize them and use a applicator that can be adapted to the specific anatomy of the patient. So in this case, it was growing a little more outside to the right side of the patient, and so we added additional channels, additional needles to be able to cover that extension to the right side of the body. And that's sort of what that looks like. So we can have this cylinder that goes in the vagina and then basically add these channels wherever we need them. And that's all done under ultrasound guidance, so we use the minimum number required to limit the morbidity of the procedure. So that's the majority for the cervical cancer. One thing to add is the treatment timeline is critical. So for example, a patient who's treated on island getting the external radiation but needs to come and get the internal radiation treated abroad, there's a very tight time window. Once you've completed the external radiation, we only have about 2 or 3 weeks to complete the internal radiation. So that requires some strict coordination to make sure that everything can be booked, arranged, because beyond that, the chance of success actually decreases by about 1% per day. And how exactly we do this depends on the patient, the size of the tumor and all that, whether they stay in the hospital for all these treatments or they just come each day and have these done. But the most important thing is to have high quality internal radiation because, again, about half the dose to these tumors comes from that. And if that's compromised in some way, the chance of cure will be much lower. In terms of future directions, there are some research challenges in the sense that there is thankfully declining incidence rates because of good screening with pap smears and prevention with HPV vaccine. And treatment is generally very effective, although nothing is 100%, and so Dr. Joseph later will talk about some of the novel systemic approaches that we're using for some of the very advanced cases or when these spread, and that includes looking at personalized medicine and ways that we can work as a team to use every modality that we have to try to cure as many people as possible. The next common cancer is endometrial cancer, and this primarily affects postmenopausal women, whereas cervical cancer often affects premenopausal women. There's not necessarily the greatest screening methods. The most common presenting symptom is postmenopausal bleeding. So when bleeding happens after menopause has set in, that's a red flag and needs urgent attention. And so these are some of the risk factors, protective factors, and additional sort of things to note for people that may be at risk for this. The way that this is staged is a little different than cervix cancer. It's really not relevant how big it is in terms of how many centimeters or inches the tumor is, but how deeply it invades into the muscle of the womb, of the uterus. And then there's additional prognostic factors that we look at under the microscope to help stage people, to help see what their risk level is and what treatments they need. And so for the earliest stage ones, thankfully surgery may be enough if it's only grown into less than half the muscle of the uterus. But in certain more aggressive ones, we have to give some radiation with either just in the vagina, where basically after your hysterectomy, you have some sutures placed, a little scar at the top of the vagina. We can treat that with radiation because that's the most common area of recurrence, about 70%. Or in some cases, we do a more similar to the cervical cancer, where we treat the whole pelvis when there's risk of lymph node involvement in the future. So for the standard kind of early stage endometrial cancer that need a little bit of a boost to kill maybe some microscopic cells at the top of the vagina, this is what we do. It's called intravaginal radiation therapy, and it's exactly what you think. You have a vagina placed into the, a cylinder placed into the vagina, and you only need to do 3 treatments basically to sterilize that scar and reduce the chance that something can grow back there to 5% or less. For the management of high-risk endometrial cancer, there's differences in opinion, and different institutions do this in different ways. Some people do chemotherapy alone and maybe add that cylinder treatment. Other people do actually chemotherapy and radiation at the same time. And this depends on, the nature of your cancer, how many lymph nodes are involved, and basically all of our patients are discussed in a multidisciplinary group to try to find the best sort of plan. And so there's these minutiae based on these trials that we sometimes will discuss at length to get, the best plan for each patient. So here's one case of a recurrent endometrial cancer. The ages and dates are, changed for anonymity, but basically had initial surgery, chemotherapy afterward. She declined radiation at that time, and unfortunately had a recurrence a couple years later in some of the lymph nodes. Had more chemotherapy, was still afraid of radiation, but by 2021, had more growth and was told, the best way to cure your cancer is if you consider doing some radiation. And she was very concerned about toxicity. She had a lot of lymph nodes involved. And so we discussed, in her case, doing proton therapy for that beam stopping advantage, where you get less of that radiation spillage to the other organs. So she had 5 weeks of radiation. And so you can see, I don't know if I have a laser pointer, but here's her PET scan where you see a couple of the lymph nodes, one of them just in front of the bone there on the left, and then the other one in front, towards the front of the body, that brightest spot. So those are those lymph nodes. And we use these PET scans to help guide the treatment for the high radiation boosts. And so this is what her plan looks like. So basically treating those sides of the pelvis to the higher dose and trying to spare the midline to avoid sort of nausea and diarrhea and those sorts of side effects. She had a great response, it was tolerated well, and, didn't develop any long-term side effects, which was great for her, and, doing well. In terms of these controversies, so as I mentioned, the treatment of advanced stages is somewhat controversial. There's a few different ways that you can sort of perceive these cancers. Certain histologies are more aggressive, and, we wonder, can we do more? And in the recurrent or metastatic setting, the consensus on how to manage these can become sort of complicated as well. The most recent practice-changing trial is looking at adding immunotherapy for these. And the most anticipated one is looking at, who would do well with less treatment and who needs more treatment, looking at molecular sort of markers in people. And so those are, the future directions, is looking at those high-risk histologies. So the last major topic is looking at oligometastases. So these are when your cancer has spread, you're actually stage 4, but it's only a few spots. And so radiation is a very powerful tool for these sorts of cancers, because can you avoid the toxic effects of chemotherapy by basically zapping these limited number of areas? And so there have been some trials looking at this. This is a review published in 2024 where, each lesion treated very high local control, and people had, almost 2 years of not needing any other treatment because they didn't have any more progression. And so this is another trial looking at the same thing. And so radiation is a very powerful tool, and we have all of these different options. We have the particle therapy, the protons, conventional photons, brachytherapy, internal treatment. We have MRI guidance. And so I'm going to show you briefly a few of these technologies in action. So this is an isolated lymph node in the supraclavicular fossa. That's a common site of recurrence in cervical cancer. And so you can see in the front of the body, in front of the lung there, she's this little lymph node. And so a standard radiation machine is great at knocking this out. And no issues there. Second case, a recurrence in the lymph nodes in the abdomen, and so this is a little harder because you have all of your small bowel, all of your digestion, and your duodenum, and those structures, and so there in the front of the bone there is the lymph node there, and so this is where I don't know if I have to press something to get this to play. Yeah, so we can actually on each patient redo the whole plan that normally takes 2 weeks in a couple of minutes and redraw everything and track where the lymph node is because it moves with breathing and all of that. And so we create a new plan basically each day with our physicist, and we can track the tumor and the bowel during the treatment, during the whole treatment. And this is the most powerful tool we have now to really dose escalate when you need to. And so this is what the patient would see, actually, is that they would see that they're controlling their breathing, and they're seeing that the smiley face means that they're, just hold your breath, we're treating the tumor well, and, the bowel is outside of the field. So, we actually talk to our patients the whole treatment to make sure that this gets done properly. And then this is, what we see on our end. We see more than the smiley face. We actually see the whole bowel moving back and forth. And, people do great. So this last case is looking at a recurrent ovarian cancer, an international patient. She had this small little recurrence near her rectum. So I put a couple needles in it, did brachytherapy. She really had no side effects. And by doing that, you can avoid, many, many weeks of external radiation by just sort of ablating it locally. And, she's no evidence of disease. One thing we look at is the total dose to all the organs. And, the rectum got an equivalent of basically what we call 10 gray. So that's an extremely low dose. Even for the palliation of a tumor, usually things get at least double that. Meanwhile, the tumor, if you look at the sort of top row, where you see the green, where our goal is, 80 to 90. In this case, we did 72.4. This spreadsheet is made for cervical cancer, but just to illustrate that in just 3 treatments, you can get 70 gray, which is the standard that people are getting over 7 weeks in some instances. And then very last thing, when we're treating a uterine cancer that no one can have surgery for because of medical issues, we've even done this where we're watching the whole time the uterus. And so, can we move this non-invasive needle forward? But I think simple is often best. This is a case where she couldn't have a surgery, but she could undergo anesthesia. You stick in this applicator and, and she did great. So, in summary, even when cancers have spread, we can really still go after them and have great outcomes. And we have this synergy between external and internal radiation where we can control, the microscopic disease with the external and give these high-dose boosts with the internal radiation. And so that's, the bulk of what I do. And thanks again, everyone, for attending and for giving me this chance to speak. Thank you.